Raz. Okay. Esteemed jury, dear participants, listeners, ladies and gentlemen. On behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in International Medical Congress of Silesia 2023. My name is Karolina Ziaja, and I have an honor of moderating International Medicine session during the International Medical Congress of Silesia, SIMC 2023. I would like to cordially welcome the esteemed jury, President of the jury, Professor Grzegorz Cieślar, and members of the jury, Professor Joanna Glik, Professor Joanna Musialik, Dr. Ewelina Krupa. We would like to explain you the rules of the session. The order of the presentation will be the same as in the abstract book. The maximal time of presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please do not admit points to the presentation. Other members of the same clinic are able to assess the presentation. The assessment will be verified. All the presentations and the discussion must be run in English. I would like to remind that if the work must be presented in English, the discussion also must be run in English. We kindly ask the jury to assess scientific value from 1 to 5 points, way of presenting also 1 to 5 points, discussion also own contribution. When the session ends, we kindly ask you to give the tablets back to the coordinator or save results on your assessment from online. To begin, I think that we can start with the first presentation. Okay, so I would like to present the first paper, Laboratory Parameters and a Prediction Factor for Fatal Outcome Among Patients Infected with COVID-19 by our online participant. Are you with us?
Yeah, can you hear me?
Yes, but 1 second because we can't see your presentation.
Yes, we can hear you.
Okay, so I can start.
But
my name is
please,
Ekaterina, and I'm a Riga Strategic University student. And today I'm going to present my scientific work, Laboratory Parameters as a Prediction Factor.
Yes, we can hear you.
Okay, so I can start. My name is Ekaterina, and today I'm going to present my scientific work.
Can you re-upload the presentation?
So I can talk, yeah, and share presentation, or?
Yes,
Okay.
you can upload the presentation.
So can you see my presentation now?
Yes, we can see.
Yes.
Yes, okay. So my name is Ekaterina and I'm from Riga Strategy University. And today I'm going to present my scientific work, laboratory parameters as a prediction factor for fatal outcome among patients infected with COVID-19. So since the first case of SARS-CoV-2 was reported in 2019, the coronavirus disease has been at the center of human attention. This pandemic has created significant challenges around the world, and our understanding of this disease continues to evolve. The aim of this study was to investigate the profile of laboratory parameters in SARS-CoV-2 patients to identify parameters associated with a higher risk of mortality. And to achieve the goal, the study included and retrospectively analyzed the medical histories of 410 patients who were hospitalized at Jelgava City Hospital in Latvia between October 2020 and January 2021 with SARS-CoV-2 infection. Information about clinical characteristics as well as laboratory parameters was collected. The collected data was analyzed with descriptive statistics, ROC curves, and Cox proportional hazard progression. So the results of the 410 patients, 236 patients were women and 174 men. The median age was 71 years. 105 patients died, 45 were transferred to another hospital, and 260 were discharged. The median age of discharged patients was 66 years, while the median age of deceased patients was 80 years. And out of 410 patients, the condition of 272 patients after examination in the department was described as moderate. 40 patients were in a severe condition and 10 patients in a very severe condition. In the admission department, vital signs were determined for all patients. So after laboratory confirmation of the SARS-CoV-2 infection, patients underwent a blood test within 24 hours. It was found that diseased patients were to have elevated D-dimer levels with median 3.08 milligrams per liter, elevated erythrocyte sedimentation rate with median 35 millimeters per hour, and a mild leukocytosis. Biochemical rates also showed changes in patients who died. Elevated ferritin levels were observed in the deceased patient group. Also elevated aspartate aminotransferase, lactate dehydrogenase, urea, creatinine, C-reactive protein, troponin T, and glucose. ROC curves were constructed to find out how high quality and effective these laboratory metrics are in predicting patient mortality. Of the 16 laboratory metrics, 12 parameter elevations were found to be associated with higher mortality. Troponin T was found to be the best predictor of mortality with a high specificity and sensitivity. D-dimers also showed high specificity and sensitivity. C-reactive protein was found to have a high sensitivity but slightly lower specificity. Glucose and aspartate aminotransferase showed high specificity but slightly lower sensitivity. On the other hand, for lactate dehydrogenase, the area under the curve was slightly lower, but the specificity of the test was great. hazard ratios were calculated by univariate and multivariate Cox regression for parameters with a cutoff value greater than the reference interval. Patient's age and gender were also included in the multivariate model. Of 12 parameters analyzed with ROC curves, the limit value found for 8 parameters were found to be higher than the reference interval. A hazard ratio was calculated to compare the effect of these 8 laboratory parameter limit values on survival. In the univariate model, a statistically significant hazard ratio was found for all cutoff values as well for patient age. Namely, when the age increases by 1 year, the risk of dying increases by 2.6%. It also was found that, for example, elevated D-dimer level increases the risk of mortality by 2.9 times. Elevated ferritin level 2.6 times. Elevated aspartate aminotransferase 5.8 times. But elevated troponin T levels increases the risk of mortality 4.4 times. Elevated glucose level 4.5 times. In the multivariate analysis, a statistically significant result was found for C-reactive protein and troponin T, which means that these parameters are independent predictors of patient mortality. So it can be concluded that determining the laboratory parameters on admission, it's possible to identify patients of the risk group who have a higher risk of a fatal outcome, which in turn will allow timely prevention on disease progression. So thank you for your attention. I'm ready to answer your questions.
I'm sorry, but we have to make a small break because of the technical problems with the connection, because the participant can't hear us. So we have to restart one computer. So 1 minute before the discussion, okay?
Can I start with the first question?
Oops. Widzę, że Państwo na Zoomie niestety nie zobaczyli wiadomości pana Michała o przerwie, więc dyskusja chyba się już toczy z tego, co widzę tutaj. Także musimy sekundkę poczekać.
No, teraz raz, dwa.
Michałku, słychać cię?
Raz, dwa, trzy, raz, dwa, trzy. Niestety dalej nie słyszymy. Raz, dwa, raz, dwa, raz, dwa, raz, dwa. Raz, dwa, raz, dwa. Tutaj teraz słyszymy, ale... Raz, dwa, raz, dwa. Tak. Niedobrze. Poczekaj. A teraz? Raz, dwa, trzy. Raz, dwa, trzy. Teraz powinno być ten. Teraz powinno być. Karolina, czy możesz coś powiedzieć?
Raz, dwa, raz, dwa, raz, dwa, trzy. Raz, dwa, trzy, cztery, pięć. Raz, dwa, trzy. Wielki bracie, raz, dwa, trzy. Słychać mnie? Halo, halo, halo.
Sądzę, że możemy rozpoczynać dalej.
Czy teraz nas będzie słychać online? Can you hear us online?
Zwracam się do osób na Zoomie. Czy nas teraz Państwo słyszą? Can you hear us? Proszę włączyć mikrofony.
Tak, ja teraz pana słyszę.
Dobrze, to możemy dalej procedować. Dziękuję.
Okay, so we can start the discussion part of the first paper. Can you hear us?
So thank you for response for my question. Thank you.
Okay, so does the jury have any questions? Yes.
The first question, could you give us an example how an elevated level of any of the analyzed parameters change the or should change the treatment of the patient?
Can you hear us online? Chyba będziemy musieli, profesorze, poczekać na uzyskanie odpowiedzi jeszcze chwilkę. Can you hear us? Przepraszam, czy słychać nas online?
Czy pani profesor Joanna Glik nas słyszy?
Tak, słyszę.
To dobrze, to w takim razie widać, że wszystko działa. Karolina, ty nas tak, słyszysz, prawda?
Czy pani profesor mnie słyszy?
Ja słyszę panią, tak.
Tak? Okej, dobrze. Czy ja mam stać na scenie, żeby mnie było słychać? To chyba nie od tego zależy.
Niekoniecznie, ale dobrze to wygląda.
Dobrze. To w takim razie spróbujemy się skontaktować z naszą uczestniczką. Can you hear us? Hello. Can you say something? Can you hear us? Can you hear us? Hello.
No, we can't hear. I can.
A czy pani profesor nas słyszy?
Ja teraz słyszę. A państwo mnie słyszą?
Tak, my
Ja
słyszymy
słyszę
panią
i
profesor.
widzę panią Ekaterinę.
A słyszy nas pani teraz? Słyszy nas pani teraz?
Nie będzie, nie będzie.
Raz, raz. Okay. Can you hear us? Can you hear us? I think that you can hear us, but we can't hear you now. So 1 more minute, I think. Can you hear us now? Okay. Przepraszam bardzo za problemy techniczne i dziękuję za cierpliwość. Zmienimy. Okay, so can you hear us? Can you tell something?
We can hear you.
Yeah, we can hear you too. So now we can start the discussion part. I'm sorry for the problems with the technical things, but I think that we can start.
Okay, please give us an example how the elevated level of any of the analyzed parameters should change the treatment of the patient. You can choose one parameter and how the elevated level of this parameter should change the treatment of the patient.
Okay, I will choose troponin T, and if on admission I have a patient with elevated troponin T level, as we know in COVID-19, not most, but many of COVID-19 patients have cardiovascular diseases, different comorbidities. So if I found that the troponin T is elevated, I will also check this parameter level after 4 or 6 hours to control it. So it will change diagnostic tactic, and in future it will change treatment tactic if I found on that next step that patient is at high risk group.
Okay, thank you. And what was your own contribution to the presentation? Your own contribution in preparing this presentation?
Contribution? You mean what
did you do to prepare this presentation?
Okay, I'm the only author on this presentation, and on this work, and I have only scientific supervisor. So I collected all data, analyzed all data, and yeah, I did all the work.
Okay, thank you.
Thank you very much. Are there any other questions?
Did you look at whether the patients had any bacterial co-infection in your study?
Yeah, in case this work is a part of much bigger my scientific work, where I also analyzed all comorbidities and all treatment what the patient received in hospital. So I don't have time, maybe 7 minutes to tell you about all my work, but yeah, I analyzed also this factor and many other factors.
Okay, I thought so. Thank you.
Any other questions? Okay, so thank you very much for your presentation and for the discussion. So now we can move to the next presentation. Okay, so now we can move to the next paper entitled Analysis of the Clinical Efficiency of Omaluzumab, Medralizumab and Mepolizumab in Asthma Treatment by Julia Slążek, Wiktoria Skowron, Zuzanna Szatkowska and Błażej Szymczuk.
Good afternoon, my name is Julia Slążek, and today I will present the analysis of the clinical efficacy of omalizumab, benralizumab, and mepolizumab in asthma treatment. And this work has been conducted with the Department of Pulmonology in Katowice. Asthma is, according to the JINA definition, a heterogeneous disease, and it's a whole group of diseases actually, with chronic inflammation of the respiratory tract. This respiratory condition affects around 300 million people worldwide. It is also one of the most frequent chronic diseases in children and adults under the age of 40. The primary symptom of asthma is shortness of breath, which by patients is usually described as a feeling of tightness in the chest. Symptoms appear haphazardly and vary in severity as well. Due to the degree of severity, asthma can be divided into mild, moderate, and severe. Severe asthma requires additional treatment, and one of the options is biological therapy. This is a little too high. Da się tu niżej? Oh, okay, sorry. Patients that suffer from severe asthma usually require the use of long-acting bronchodilators, and we can use the additional treatment of biological therapy. Omalizumab against immunoglobulin type E, mepolizumab against interleukin-5, and benralizumab against the interleukin-5 receptor. And now we have also dupilumab, which has been just recently approved by the Polish government. So this is another thing that we can use. The clinical efficacy rate for prior trials is shown below, and we will conclude how the results vary. The aim of the study is to analyze the biological therapy. This was a retrospective study based on data collected over the last decade since the biological therapy treatment started in 2013. The presented data has been collected at the Department of Pulmonology in Katowice. We had 135 patients, of which 57 are male and 78 are female, and the data range has been collected from 2013. There is a mistake right on the presentation, and what has been evaluated was the quality of life, so this is AQLQ, this is asthma-related quality of life, asthma control, and the global effectiveness of therapy, as well as decrease in exacerbations and the use of glucocorticoids. The study group consisted of 135 patients, where 42%, as you can see on the pie chart, right here, is male, and 58% is female. So this can lead to a conclusion that women suffer from asthma more often than men. The age distribution was mostly 50 years old, and that also corresponds to the mean age calculated. But as you can see on this graph here, there has also been a peak in the 30 and 39 age group, which also supports the idea that it is a common disease in adults under the age of 40. The treatment type distribution is shown on this chart. As you can see, omalizumab does not contain the majority, even though it has been used since 2013. So mepolizumab has been used since 2018, while benralizumab has been introduced in 2019. This doesn't really correlate to the number of patients able to undergo the therapy. Nevertheless, on the next slide, we are able to see a summary of the effect of therapy after the first drug trial at control point 1. This is around 1 to 2 months after the first dose has been given to the patient. As you can see, omalizumab doesn't give the best outcome. The one that gives the best outcome is benralizumab and mepolizumab, which is why it is reasonable for omalizumab to be used less frequently than the other ones. And so, as illustrated on the graph, the criteria for continuation of biological therapy, which is a decrease of at least 0.5 in ACQ, so the black line below, and an increase of AQLQ of at least 0.5 as well. This further depicts that the efficacy of therapy with results seen in most cases from the first dose already. And throughout the 12 years of data, only 10 patients had to stop therapy. The exclusion criteria include asthma exacerbations that are equal or more or higher than the ones prior to starting biological therapy. An additional exclusion criteria would be a failure to meet efficacy criteria, which would be the improvement in ACQ and AQLQ parameters, or the reduction in oral glucocorticoid dose. Nevertheless, some patients have been requalified for therapy using a different pathway of a drug, and they have seen spectacular results and meeting the criteria for therapy success, and they have gained complete asthma control and now can live with a whole new comfort of life. As you can see on the pie chart on the right, there has been a significant distribution of decreased exacerbations, with omalizumab reaching 100% for all patients, and in 89% for benralizumab and mepolizumab, the exacerbations have also decreased. In conclusion, with a decrease in exacerbations in 89 and 100% of patients for both benralizumab and omalizumab, we can say that the clinical efficacy rate in our study is higher than the one in previous randomized clinical trials. In addition, despite some patients being excluded from the first trial, they have still been requalified for another treatment, but this is another thing for a case report. And thus, biological therapy does not exclude, and it's still developing, and it enables us to provide a good treatment for asthma patients. Thank you for your attention.
Okay, so now we can move to the discussion part. Does the jury have any questions?
Two short questions. First one, could you compare the clinical efficacy of these drugs with glucocorticosteroids used as a monotherapy?
Yes, so I have also, during the research for this article, for this work, I have talked with the patients that have started the biological therapy and before they haven't, and they said that when they were using the glucocorticoid, it didn't really help them. They still had difficulties with walking up the stairs, and this is a fragment that we have to ask in the asthma quality of life questionnaire. And they still had the difficulties that with asthma, and they still had exacerbations when they were, for example, walking 100 meters or 2 floors up. And when they started the biological therapy, after the first trial, it has already been better. So it was a very fast result, and they were really happy with that.
And the second question, how could you explain that the results of your study are better than in those cited clinical trials, professional clinical trials?
I think that maybe this is due to the fact that the patients that have been chosen for therapy, maybe the exclusion criteria in Poland are a little more severe than in other countries, because this was a foreign trial. So, and also the number of patients, because we only had 135 patients, and from the analyzed trials before, it was in thousands and hundreds of thousands. So there was obviously a bigger data range that was used.
Thank you very much.
Thank you.
What side effects of these drugs do you observe?
The patients didn't really mention any side effects. They were I feel like they were so happy with the results that they ignored the side effects that could possibly be. And one of the patients has also, because he was one of the patients that had to stop the therapy of both benralizumab and mepolizumab, and now he is going for omalizumab, and because he was excluded from the previous trials, and he is now even going yachting, and he is mountain climbing. So I think that the patients just don't mention any side effects because they are so happy that it finally worked.
Fine. How long was observed, this therapy?
The therapy is observed at the Department of Pulmonology, so the patient has to come and the questionnaires are conducted. So AQLQ is the asthma-related quality of life. So there, the questions are things such as walking up the stairs or coughing and exacerbations, and the asthma control is if they have required any inhalations or inspirations for the exacerbations.
Okay, thank you.
So this is how it is measured. Because unfortunately, currently the department at Katowice cannot measure the eosinophil level. Prior to when they were here in Ligota, they were able to, but now there is this smaller data range that they can find.
Okay, thank you very much. Does the jury has any other questions? Okay, so thank you very much for your presentation. So now we can move to the third paper, entitled Willingness to Undergo Screening Gastroscopy in Low to Moderate Cancer Prevalence Area, a survey study by Pelczar Monika and Budzeń Krzysztof.
I will just check the pointer, okay. So good morning, my name is Monika Pelczar, and I would like to present our study in which we aim to assess the willingness to undergo screening gastroscopy in low to moderate cancer prevalence area. Nowadays, screening gastroscopy is only performed in high incidence gastric and esophageal cancer regions such as South Korea and Japan. Poland is considered as a moderate gastric cancer and low esophageal cancer region. The EGD is essential in detecting precancerous conditions such as atrophic gastritis and Barrett's esophagus, based on which gastric non-cardiac adenocarcinoma and esophageal adenocarcinoma can develop respectively. Endoscopic surveillance and treatment of early lesions can prevent advanced cancer development. One-time EGD in searching for atrophic gastritis and Barrett's esophagus was shown to be potentially effective in low to moderate gastric cancer and esophageal cancer areas. And in the related literature, there were a potential benefit to harm ratio, and they shown that it could be as high as 28 to 47 for age group of 40 to 69 years of age. And nevertheless, we are conscious of the potential obstacle to the EGD mass screening that could be the willingness to undergo this examination. The study aimed to assess the potential willingness to undergo one-time screening EGD in searching for precancerous condition in the moderate upper gastrointestinal cancer risk population. Oh, sorry. Okay, so patients and methods. So by creating a simple online questionnaire, we collected data such as age, sex, history of EGD, willingness to undergo screening EGD, and the acceptable ratio of the potential benefits and harms of one-time screening EGD. Can I change it differently because it doesn't work? Okay. This way, okay. Okay, that's right. Okay, let's move to the results. Okay, so 85.5% were willing to undergo screening EGD, 68.8% were female, and 53.3% had not previously undergone EGD. And here is the graph. So here, yes? Okay, so the results also show that individuals who have not undergone EGD before were less willing to undergo EGD versus individuals who have already undergone EGD. The results also show that the median acceptable ratio of potential benefits to harms were 10 and presenting in age groups. So for people between 40 and 44 years of age were 100, and for people between 45 and 69 years of age were 10. So that leads to the conclusion. So the recently reported ratio was 2.8 to 3.7 times higher than the acceptable ratio in our study. And that leads to the conclusion that EGD mass screening could be potentially accepted in individuals between 45 and 69 years of age. And the higher willingness to undergo screening EGD among individuals who previously underwent EGD might be related to fear of EGD and potential discomfort during the procedure. Therefore, informative social campaign would be desired. Thank you for your attention.
Thank you very much. And now it's time for a discussion part.
How do you think, why there are different results in particular age groups?
Okay.
How could explain this fact?
Yes, of course. So, so there is a different result in youngers. So that probably the reason is I think that they are more fear and they probably are less aware about precancerous conditions that could lead to the cancer. So I think that could be the reason. So,
Okay, and what was your own contribution to this presentation?
Of course. So I analyzed the data, and of course, I was part of this. I was, of course, a part of this presentation. I did the abstract, and I did, of course, this presentation. And for statistical analysis, I asked for help to more experienced doctors and data analytics.
Thank you.
Any other questions? Okay, so thank you very much. So now we can move to the next paper entitled "Is metabolic acidosis a risk factor for worse long-term prognosis in patients after kidney transplantation?" The floor is yours.
Good afternoon, ladies and gentlemen. My name is Julia Dołęga, and today I would like to share with you the results of our observational clinical studies and answer the presented questions. Is metabolic acidosis a risk factor for worse long-term prognosis in patients after kidney transplantation? As we know, metabolic acidosis frequently occurs in patients after kidney transplantations, and the results of both experimental and clinical studies suggest that metabolic acidosis may contribute to faster progression of chronic kidney disease. Local increase of ammonium synthesis in kidney interstitium is crucial in the pathogenesis of chronic kidney disease. On one hand, the global kidney ammonia production is decreased, but compensatory ammonia production per single nephron is increased. It leads to ammonia-induced complement activation through the alternative pathway and effects with fibrosis and progression of chronic kidney disease. Our aim was to examine the relationship between metabolic acidosis and both mortality and renal outcomes in patients after kidney transplantation. We enrolled 486 consecutive patients, including 196 females and 290 males aged about 32 years old. In patients who were at least 1 year after kidney transplantation, blood bicarbonate was measured, and subsequently they were observed for 11 years. Metabolic acidosis was defined as blood bicarbonate concentration lower than 22 millimoles per liter. In our analysis, we used Kaplan-Meier survival curves, and the endpoint in this analysis were death, initiation of dialysis or retransplantations, and the cumulative endpoints of both, death and initiation of dialysis. Differences in survival curves were analyzed by long-rank tests, and they were considered significant when P was under 0.05. Relative risk is presented with a 95% confidence interval. Metabolic acidosis was diagnosed in 57 patients, in which 32 were male and 25 were female. At baseline, in the time when blood bicarbonate was measured, there were differences between patients with and without metabolic acidosis in eGFR, blood hemoglobin concentration, and serum potassium concentration. there was a differences in survival in Kaplan-Meier curves analysis. Patients with metabolic acidosis were dying earlier than in comparison to patients without it. The relative risk of death in patients with metabolic acidosis was 1.61. There was also difference in Kaplan-Meier analysis where the endpoint was the initiation of dialysis or retransplantation. The risk of renal graft failure in patients with metabolic acidosis was twice the time higher than in patients without metabolic acidosis. The risk of the cumulative endpoint of the study, death and initiation of dialysis therapy or retransplantation, was also higher than in patients without metabolic acidosis. To sum up, metabolic acidosis is an important risk factor for increased mortality and progression of graft failure in kidney transplant recipients. Moreover, the use of metabolic acidosis corrected prospective interventional studies in patients prone to allograft nephropathic progression will provide information on whether treatment of metabolic acidosis improves the survival of both patients and transplanted kidneys. Thank you for your attention.
Thank you very much for your presentation. Now we can move to the discussion part.
Three short questions. First one. The estimation of these parameters were made in arterial or venous blood?
Venous blood, because it's easier to
it's less it's easier for patient to have blood tested from vein rather than artery.
Okay. The second question, how did you collect this data? Because there is 11-year observation, so it's a difficult problem, I think. How did you get this data?
Well, we've used, because we collected data for 8, 9, 10, and 11 years after the kidney transplantation, and we used the data that was already collected. So we used the data from every patient from the Department of Nephrology, and that's how we did it.
And the last question, did you make the statistical analysis yourself?
No, we did it with help of our study tutor.
Thank you.
What can you tell us about the kidney disease before the kidney transplantation in metabolic acidosis group patients? Kidney disease before transplantation in these patients.
You ask how metabolic acidosis impacts kidney before?
No. Kidney disease in metabolic acidosis group patients between transplantation. Diabetic or nephropathy.
You mean reasons why people have...
Yes.
Okay. So the biggest cause of chronic kidney disease is...
In metabolic acidosis group patients only.
Okay. So it's diabetes.
Diabetes.
Yes.
Okay, thank you.
The main part was diabetes.
Have you got any other questions?
Have you thought about doing similar study in the future, but with case control study?
Yes, we want to prepare data and include one more statistic point would be EDFR, because it's very important to divide patients into two groups with normal EGFR before transplantations and lower than other patients have. And it will be the next step.
Thank you very much. Any other questions from the jury? Okay, so thank you very much for your presentation. Now we can move to the fifth presentation by Dawid Wilczek and Jan Herzyk.
Good afternoon. My name is David, and I am really honored to present you our retrospective cohort study about appropriateness of red blood cell transfusions in non-bleeding patients. The decision regarding red blood cell transfusion as one of the most common types of transplantation constitutes a daily challenge to hospital physicians. Transfusion of RBC may lead to many additional health issues, such as transfusion-associated cardiac overload, transfusion-associated acute lung injury, pneumonia, and early and delayed hemolytic reactions. Finally, RBC transfusion may lead to increased mortality and longer hospitalization. Okay. On the other side of risk-benefit assessment, we should consider the issue of anemia. Anemia is an independent risk factor of myocardial infarction, stroke, acute kidney injury, and infection. Even mild anemia doubles long-term mortality and may increase the longer of hospitalization. So, the aim of our study was to investigate the appropriateness of red blood cell transfusions in non-bleeding patients hospitalized in a large academic medical center. We performed a retrospective analysis of all RBC transfusions performed in non-bleeding patients between January and July 2022. During this period there were 828 units transfused to non-bleeding patients. We excluded 301 RBCs that were transfused because of bleeding and 104 that were transfused as a preparation for surgery. There were 171 RBCs given as a single unit transfusion and 657 units as a multiple unit transfusion. The main causes of inappropriate RBC transfusion included no hemoglobin determination pre-transfusion, absence of anemia signs and symptoms, and hemoglobin concentration higher than 80 grams per liter. We evaluated appropriateness of RBC transfusion according to the most recent clinical practice guidelines recommended by Association for the Advancement of Blood and Biotherapies. Most appropriate RBCs were transfused because of neurological dysfunction with hemoglobin level lower than 70 grams per liter. Almost 21% were transfused because of severe anemia, and 16.7% due to dyspnea despite oxygen therapy. Suitable level of hemoglobin with hypoxia exponents or coronary artery disease with any anemia symptom or tachycardia and hypotension was an indication for about 7% of appropriate units for each one. Only 6 RBCs were transfused because of acute cerebral ischemia with coexisting level of hemoglobin lower than 80 grams per liter, and there wasn't recorded any unit because of anemia appearing by acute coronary syndrome. As you can see on this slide, there was no difference between each group apart from hemoglobin concentration, which is obvious in context of indications that I mentioned earlier. Out of more than 24,000 patients, 286 patients received at least a single RBC unit. The overall incidence of RBC transfusions at our institution was 10.2 unit per 1,000 patient days. The incidence of RBC transfusions was highest in the autoimmune and metabolic diseases department, intensive care unit, and clinical pharmacology department. The percentage of RBC transfused patients was also highest in these 3 locations. As you can see, the highest incidence of appropriateness was in the appropriate RBC transfusions was in the intensive care unit in number of 23.1 units per 1,000 patient days, and in the autoimmune and metabolic diseases department in case of inappropriate RBC transfusions. To sum up, I would like to say that the main causes of inappropriate classification were multiple unit transfusion episodes, absence of anemia signs and symptoms pre-transfusion, and adoption liberal transfusion triggers. So there is still need to educate physicians on appropriate indications for RBC transfusion to minimize the potential complications and RBC over transfusion. Thank you very much for your attention, and I am here for your questions.
Thank you for your presentation.
I must say that I am very confused listening to these results because 76% of inappropriate transfusions is horrible in a very big and very important hospital. How could you explain such huge, such horrible percentage of these inappropriate transfusions?
So the main reason was no hemoglobin concentration before transfusion, so we couldn't check if this transfusion was appropriate. For example, we had many situations where, for example, 2 days ago, the concentration of hemoglobin was approximately 11 grams per deciliter, and then doctors performed a transfusion. Moreover, the second point is that there are too many double unit transfusions. All the studies suggest that after one transfusion, we should perform another blood test to explain how did the hemoglobin level changed. Answering to your question, a few years ago in Journal of Transfusiology, it was a well-published article about multi-center study, and they showed that approximately 50% of all blood components, including red blood cells and platelets, were transfused inappropriately in some state of the United States. And moreover, this study was performed due to committee which is working in our hospital, transfusion committee working in hospital, and the president is of this committee is our tutor. And after implementation of some guidelines which he made in December and November-December, we are going to perform study comparing the appropriates of red blood cell transfusion after his after implementation of these guidelines, and now we are collecting data and we are waiting for the results.
I congratulate this valuable idea.
Thank you.
Thank you.
Any other questions?
Would you consider calling a blood transfusion a transplant?
We are aware that RBC transfusion, we believe that it's most common type of transplantation, because we know that this is the issue. This is the allogenic issue for the patient. So if we do the transfusion during the hospitalization, we believe that we can call it as a transplantation.
Okay, thank you.
Any other questions? Okay, so thank you very much for your presentation. And as I know, we don't have the authors of the sixth presentation. Am I right? It's the work about retrospective analysis. Okay, so we can skip to the seventh paper. Okay, so now I would like to invite Rainis Ozols.
Hello, I hope you hear me.
Yes, we can hear you.
Can I share screen?
Of course you can. Wait a minute, please. Okay.
So, do you see my screen as well?
We can see your presentation. You can start.
So, hello, dear jury. I'm Rainis Ozols from Medical University, and I will tell you about my research, Latvian patient outcomes following pulmonary angiography performed in Riga and Vienna from 2013-2022 data. So we used, our methods was to prospectively monitor patients before operation and 1 year after operation, and we used 6-minute walk tests, echocardiography, and cardiac catheterization to evaluate operations results. Why this research was important is because pulmonary hypertension is a common disease, but chronic thromboembolic pulmonary hypertension is rare but treatable form of pulmonary hypertension, and in Latvia, incidence and prevalence is around 5.1 and 15.7 cases per million, respectively. Also, for chronic thromboembolic pulmonary hypertension, the method of first choice is pulmonary angiography, in which patients be evaluated in this research. Why this theme is important nowadays is because in 2022, European Society of Cardiology have changed some diagnostic criteria and methods for chronic thromboembolic pulmonary hypertension diagnostics and treatment. So our research goal was to assess the effectiveness of this procedure for Latvian patients and evaluate our current treatment tactic, does it match the results so far? In the research, we collected the literature data, analyzed our patient before and after operation data to see how well this patient outcome was for Latvian patients who were operated in Riga and who were operated in Vienna. Have to remind you first that to diagnose CT-APH from 2022 guidelines, it says that have to perform a right heart catheterization in which we see MPAP greater than 20, PCV less than 15, and also PVR more than 3 Wood units. And this right heart catheterization has to be performed at least 3 months after effective anticoagulant therapy. And why I said that nowadays the patient, I mentioned that these guidelines has changed, and compared to 2015 guidelines, there has been changes in diagnostic of MPAP, reduced MPAP from before it was greater than 25 millimeters, and now it's more than 20 millimeters. That's why there could be increase of patient amount in next few years. So about our research, we included 13 patients who are all patients in Latvia to whom have been performed pulmonary endarterectomy, and the average age of our patients was 49 years old. The most common risk factors to our patients was hypertension, hyperlipidemia, smoking, and history of pulmonary embolism events, but not all patients had these risk factors. About the demographics, in European and Canadian population, around 75% of CT-APH patients have had pulmonary artery thromboembolic embolism events in prior history, but in our study, only 23 patients had these pulmonary arterial thromboembolism events in history, which we can. We believe that this was due to our small sample size, not because in Latvia these pulmonary arterial thromboembolism cases would be less. So our patients were operated around 18 months after diagnosis, and so all patients were prescribed anticoagulant therapy using vitamin K antagonists, which are first choice for these patients for the period till the operation. But we didn't find that this time from the diagnostics to operations would affect anyhow our patient survival rate. As we can see in this diagram, to most of the patients, MPAP was reduced, but we can see this difference from operation performed in Latvia and operation performed in Vienna. As you can see, in Vienna, in patients who were operated in Vienna, these results increased way more than patients who were operated in Latvia. But to evaluate the effectiveness of the operation, we performed 1 year after the operation this right heart catheterization to see how much has changed PVR, and we also evaluated 6-minute walk test. But during a literature study, we found that some studies also indicate that cardiac index is also important to predict patient survival. That's why we also looked at these values. As you can see here, PVR also similar to MPAP also were improving more to patients who were whose operations were performed in Vienna than in Latvia. But as you can see, even in Latvia operated patients, this PVR also were improving. So we can see that operation performed in Latvia also was successful. And also 6-minute walk test was increasing to all patients, also for those who were operated in Latvia. As I mentioned about cardiac index, here you can see that to most, not to all patients, cardiac index improved, and similar to other studies where it was mentioned that cardiac index indicates patient survival rate. Also, in our study, we noticed that patients whose cardiac index after operation was less than 2 had reduced survival rates. In this case, only 2 patients who have passed away in after operation period. Their survival rate was 6 and 7 years. So after. On average, we can see that mPAP to all patients reduced on average for 20 millimeters, PVR reduced almost to 5, and 6-minute walk test increased around 150 meters. And these 3 values were statistically significantly changed, and that showed that this operation also operated in Vienna and in Latvia were effective to treat CT-APH. Here you can see life expectancy for all patients, and as you can see in Latvia, Latvian patients, 1, 3, 5, and 8 year survival rate was 77, 77, 72, and 58%, which maybe isn't as good results as in European registers, but that could be due to our small sample size. But we can already see that there are still ways where to improve PA pulmonary endarterectomy treatment for patients in smaller populations. So we can conclude that although pulmonary endarterectomy is a great and the best way to treat these patients in smaller populations, there's need to treat these patients in multidisciplinary teams in all stages of patient care, but the operation should be performed in specialized expert centers. That's why in Latvia, since 2015, we already try to send all patients to be operated in Vienna, but in Latvia, we see that there is great potential for balloon pulmonary angioplasty, which has been started doing only since 2021. So we should, in the future, we should try to see the potential of balloon pulmonary angioplasty in smaller populations like Latvia, because this treatment method maybe is greater for smaller populations, while pulmonary endarterectomy is more suitable for expert centers with bigger populations. This is my literature list, and thank you for your attention. I'm ready to answer to your questions.
Thank you very much. Any questions?
I have 2 short questions. First one. Why the diagnostic score of MAM-PAP was 20 as compared to the guidelines in which it is 25?
In European Society of Cardiology 2015 guidelines, the limit was had to be greater than 25 millimeters, but in 2022 they changed the guidelines to 20 millimeters. That's like they reduced the limit of this diagnostic limit when we approved the diagnosis. That's why, like in nowadays, this is nowadays to diagnose a patient with this disease, mPAP has to be at least 20. 8 years ago, it was 25.
I see. And the second question, what was your own contribution to this presentation?
I was collecting all the...
What did you do yourself?
Yeah, I was the only one who was doing this research, so I was the one who collected all the data from patient histories, and also helped to collect data from the patients who came to visits in last 2 years.
And did you take a part
from 2013 till last year?
Okay, and did you take a part in these procedures?
I was only as an observer in these procedures.
Okay, thank you.
Any other questions from the jury? Okay, so thank you very much for your presentation. And now we can move on to the next presentation.
Just take it. It'll be easier. Good afternoon. My name is Tomasz Siewierski, and I'm a fifth-year medical student here at the Medical University of Silesia. And today I have the pleasure of presenting to you our work titled The Assessment of Association Between Blood Pressure and Intraocular Pressure in Patients with Glaucoma. I would like to sincerely thank Dr. Sebastian Simek for watchful supervision over our project. My presentation will be divided into 5 main parts. After a brief introduction, I will outline the aim of our study. After that, I will describe the methods we used. Next, I will show you the results we achieved using said methods. And lastly, I will share with you our conclusions. So to start, glaucoma is the leading cause of blindness worldwide, and both high blood pressure, BP, and high intraocular pressure, IOP, have been linked with increased risk of glaucoma. And while these two are both distinct physiological measures, there is good evidence to suggest that they're linked in the pathophysiology of glaucoma. So probably most of us are aware what blood pressure is, but might be different for intraocular pressure. So IOP is determined by the balance between the amount of aqueous humor that the eye makes with the ease that this humor leaves the eye. And it can be determined from the equation, a Goldman equation, that is presented on the slide. In it, PO represents the IOP in milliliters of mercury, F is the rate of aqueous formation, C is the facility of outflow of said aqueous formation, and PV is the episcleral venous pressure. The aim of our study was to compare the BP and IOP measurements in patients with glaucoma with the same values in healthy students to evaluate potential relationship between said variables in those two groups. Our study group consisted of 17 patients, 12 women and 5 men with glaucoma, so 34 eyes in total, and they were aged 43 to 82, quite a big range there. And our control group consisted of 25 students of Medical University of Silesia, aged 23 to 29. In this group, we had 14 women and 11 men, so 50 eyes in total. And each person from those groups underwent a blood pressure test and an intraocular pressure test of both eyes. Now, a bit more about how the tests themselves were conducted. We used an automatic tonometer and a blood pressure monitor. Probably all of us are aware how a blood pressure monitor works. It registers the resistance that is encountered by the blood flow, resistance of the arterial walls. But an air tonometer, or an automatic tonometer, also known as an ear puff test, is a simple and not maybe safe in all occasions, but a simple and non-invasive method of registering intraocular pressure. How it works is the patient is seated and the device puffs a small amount of air onto the surface of the eye, and that bit of air flattens the cornea, and as the cornea is flattened, the device measures the changes in the pressure within the eye. To be included in our study group, a patient had to be diagnosed with glaucoma and had to show some signs of hypertension. However, he could not be below the age of 18, have untreated hypertension, or any other ophthalmological diseases, for example, a cataract or AMD. Moving on to our results. In the control group, the average BP for women was 126.8 over 83, while for men it was 132.8 over 80. When it comes to the research groups, those values were 156.6 over 83 for women and 150.2 over 73 for men. When it comes to IOP, in the left eye, the average in the control group was 17.5 and 20.5 in the research group. When it comes to right eye, the average in the students group was 17.8 and 18.9 in the patients with glaucoma. Here, these results shown in a form of table. We can see a clear split in both BP and IOP in the control and the research group. The slide shows two graphs, the first one being a graph showing a graphical representation of systolic and diastolic blood pressures within the two groups. And the second one shows the average IOP of the left and right eye within those two groups. To conclude, taking into consideration the collected data, we cannot yet state a definitive correlation between BP and IOP in our research group. However, we plan on continuing our research and focus on many different parts of this question. And based on the related literature, we can assume that such a correlation does exist, but we believe that our work may still prove to be valuable and may yield interesting results given our chosen study group. I thank you for your attention, and now I invite you to the discussion part of our presentation, and I would like to welcome to the stage my colleague.
Thank you very much for your presentation. Any questions?
I have some questions regarding the methodology of this experiment. Because could you explain what was the sense to compare young people with adult people? It is obvious that the values of the arterial hypertension must be different because of many mechanisms. And in fact, you didn't compare precisely the correlation between the arterial hypertension and intraocular operation, intraocular pressure in study group, because there are no results regarding the correlation value.
As I've said, we are still in the middle of doing our research. This is just to show what we've done so far. Thank you for a good question. And yes, we are obviously aware that the study and control group are quite different when it comes to the age range. But we, at the start of this project, we wanted to take patients with glaucoma and compare them to healthy patients. It just happened to come out that those patients are in different age groups. But we plan on obviously widening the scope, and when we encounter and widening the age ranges of both the control group and the study group. So then we can actually perform a deeper statistical analysis and answer some of these questions.
And a second problem, you have big difference between a ratio of both sexes in both groups. Yes. It's a problem. And the other problem is what was the effectiveness of the treatment in patients with glaucoma and with hypertension? Because maybe this is the reason, if these patients were successfully treated, maybe that is why the values in the control group, I mean intraocular pressure, were similar to those in the experimental group.
That's actually a very interesting question, since we are actually right now focusing on the pharmacology aspect, since we have most patients that had glaucoma were treated in some sort of way and also had some drugs relating to hypertension. And we plan on focusing that on this aspect in the next stage of our research. So we have not done the analysis so far, but yes, that is the next part of our research, actually focusing on the pharmacology and the treatment of these patients.
Thank you very much.
Thank you very much.
Any other questions from the jury? Okay, so thank you very much for your presentation.
Thank you so much.
And now last but not least, the last presentation by Julia Dziarska, Martyna Gąsiorek, Gabriela Gawlas, Mikołaj Sawiński and Klaudia Szarek.
So, good afternoon. My name is Gabriela Gawlas, and I would like to present a work entitled Molecular Characterization of Clostridioides difficile strains isolated from fecal stool samples obtained from pulmonological patients with antibiotic-associated diarrhea. It was created at the Department and Laboratory of Medical University of Silesia in Katowice. So firstly, I will provide a brief overview of Clostridioides difficile. Clostridioides difficile is gram-positive, spore-forming anaerobic bacillus. Ribotypes 027 are dominant in Poland. Also, this ribotype is responsible for the severe course of pseudomembranosus colitis. It is characterized by overproduction of toxin A and toxin B, which can be detected in diarrheal stools. The hallmark is multi-drug resistance. Also, this ribotype is hyperepidemic. Let's move to the next point. This graph presents a breakdown of epidemiology of Clostridioides difficile infection in Poland. According to the latest available reports, the number of Clostridioides difficile infection in Poland is rapidly increasing. In 2021, more than 50% of epidemiological outbreaks were caused by this pathogen, excluding SARS-CoV-2. Immunosuppression, older age, and antibiotic therapy predispose to infection, especially using fluoroquinolones, clindamycin, and cephalosporin third and second generation. Patients with pulmonological disorders, which stool samples we analyzed, have most of these characteristic features. The aim of our work was to search for genes encoding glutamate dehydrogenase antigen, GDH antigen, to confirm that we are dealing with the Clostridioides genus. Secondly, we search for genes encoding toxin A and toxin B, whose presence may determine hypervirulence. We also search for binary toxin, which is characteristic for ribotype 027. Finally, we search for RMB genes, which determine MLSB resistance, that means macrolides, lincosamides, and streptogrammin B resistance. The material consists of 56 stool samples of diarrheal stool obtained from pulmonological patients. After anaerobic incubation on appropriate media, including chromogenic media, PCR and electrophoresis was performed, and then visualization of genes using GeneBox device. Let me summarize the main points. In all samples, GTH antigen was detected. Binary toxin was detected in 36 strains, which represents 64% and may suggest a more severe course of Clostridioides difficile infection. The RMB gene was identified in 23 strains, representing 41%. Also, the photography shows the visualization of strains. The first and second columns are negative and positive controls, while the visualization of patient genes are presented from the third column onwards. To sum up, the detection of binary toxin, toxin A and toxin B suggests that we may be dealing with ribotype 027, which can cause a severe course of Clostridioides difficile infection. Almost half of the test strains shows MLSB resistance, macrolides, lincosamides, and streptogrammin B resistance. In the future, we are planning to investigate the resistance of Clostridioides difficile strains obtained from patients in Silesia to another antibiotics. And thank you for your time and listening. If there are any questions, we would be pleased to answer them.
Thank you very much for your presentation. Any questions?
One question regarding the conclusions. Why do you think that the strain which produce binary toxin is this ribotide species? Only ribotide strains produce binary toxin, or other strains also?
No, the binary toxin is produced also by ribotype 0176, but it's this ribotype 027 is more common.
I think. What was your own contribution to this presentation?
Thank you for this question. Our own contribution was assisting our tutor during activities related to prepare breeding to our Clostridioides difficile strains, especially during PCR and electrophoresis.
And last question from me. How many people with this species producing binary toxin had diarrhea? What was the ratio?
All of 56 samples were from patients with diarrhea.
So every patient had
there's
diarrhea?
Yes.
Okay, thank you.
Any other questions? Okay, so thank you very much for your presentation.
Thank you so much.
Okay, so it was the last paper presented today. So I would like to congratulate all of the participants and the authors of the presentations. At this point, I would like to ask the Professor Cieślar for a few words to sum up the session.
Dear participants, I would like to congratulate you. Very interesting presentations. I hope that the participation in this session was for you an exciting experience. I hope that very successful for some of you that will take first three places regarding the results of our judgment. I hope that it won't be the last form of participation in scientific experience, and maybe next year some of you will come both here to present new, interesting and valuable presentations. So I wish you all the best and thank you once more for your participation in this session. Thank you very much.
Thank you very much, Professor. And now I would like to invite you for the decoration and closing ceremony of the SIMC 2022 conference, which will be held on Friday at 4:15. On the behalf of the Students' Scientific Society, I would like to thank you for your participation in this session. Thank you, jury. Thank you, participants.